My name is Paul Forfia. I'm a cardiologist and pulmonary hypertension specialist. I'm a professor of medicine at Temple University Hospital, and I serve as co-director of the pulmonary hypertension, right heart failure, and CTEPH program at Temple University Hospital. Today, I'll be talking to you about right heart function and the Freedom EV study. When thinking about risk status and right heart function, we're often asked whether risk status correlates with right heart function, but we need to think about it another way. When a person's parameters of risk, such as their functional class, their walk, and their BNP are all improving, it is not that these parameters are correlated with right heart function. It's that the improvements in risk status are directly caused by the improvement in right heart function. First, it's important to note that the majority of our patients who are on therapy with PAH fall into an intermediate risk group. When we recognize that being in an intermediate risk group puts you at a 5-year survival that can be as low as 50%. Now, if you actually look at some recent data that was published, it actually shines even a brighter light on this issue. So this was actually a retrospective study of 180 patients who were treatment naive, who were then treated with dual upfront combination therapy. And then the patients had a repeat right heart catheterization 6 months after initiation of dual upfront combination therapy. And so we've got in this study a 35% reduction in the PVR on average, but our target is probably something more like 50 to 60%. Freedom EV study was an interesting study that compared Orenitram versus placebo in a group of PAH patients who were already on established oral monotherapy. Despite the relative stability of the PAH cohort at the time of enrollment, the patients who were treated with Orenitram and followed over time experienced a 61% reduction in relative disease progression as compared to placebo. When we look at the hemodynamic substudy of Freedom EV, we see that there was a 20% reduction in the pulmonary vascular resistance in the Orenitram group, and in turn, a 19% increase in the cardiac output. That relative increase in the cardiac output, of course, mirrors the relative fall in pulmonary vascular resistance, and it speaks to the relative unloading of the right heart in response to Orenitram. When we take a non-invasive look at the heart in the overall Freedom EV study, we see that there was a 41% difference in the NT-proBNP level in the patients at 36 weeks. And this speaks to the relative offloading of the heart from the hemodynamic standpoint and also from the biomarker standpoint. Within the hemodynamic substudy, you had a 20% reduction in the pulmonary vascular resistance. You had a 19% increase in the cardiac output. You had a 41% difference in the NT-proBNP levels. So when you take a step back, you're seeing hemodynamic improvements leading to biomarker improvements, leading to risk shift within the patient population. When you study a patient population that is having all of these positive hemodynamic, biomarker, and risk shift effects occurring, it is internally consistent and makes sense that if you study the patient cohort long enough, you will actually see a relative reduction in the risk of death within the cohort.
Orenitram treprostinil extended release tablets. Indication: Orenitram is a prostacyclin mimetic indicated for treatment of pulmonary arterial hypertension, PAH, WHO Group 1, to delay disease progression and to improve exercise capacity. The studies that established effectiveness included predominantly patients with WHO functional class 2 through 3 symptoms and etiologies of idiopathic or heritable PAH, 66%, or PAH associated with connective tissue disease, 26%. Important safety information for Orenitram. Contraindications: avoid use of Orenitram in patients with severe hepatic impairment, child Pugh Class C, due to increases in systemic exposure. Warnings and precautions: abrupt discontinuation or sudden large reductions in dosage of Orenitram may result in worsening of PAH symptoms. The Orenitram tablet shell does not dissolve. In patients with diverticulosis, Orenitram tablets can lodge in a diverticulum. Adverse reactions: In the 12-week placebo-controlled monotherapy study and an event-driven placebo-controlled combination therapy study, adverse reactions that occurred at rates at least 5% higher on Orenitram than on placebo included headache, diarrhea, nausea, vomiting, flushing, pain in jaw, pain in extremity, hypokalemia, abdominal discomfort, and upper abdominal pain. Drug interactions. Co-administration of Orenitram and the CYP2C8 enzyme inhibitor gemfibrozil increases exposure to treprostinil. Therefore, Orenitram dosage reduction may be necessary in these patients. Specific populations. Animal reproductive studies with Orenitram have shown an adverse effect on the fetus. There are no adequate and well-controlled studies with Orenitram in pregnant women. It is not known whether treprostinil is excreted in human milk or if it affects the breastfed infant or milk production. Safety and effectiveness of Orenitram in pediatric patients have not been established. Use of Orenitram in patients aged 65 years and over demonstrated slightly higher absolute and relative adverse event rates compared to younger patients. Caution should be used when selecting a dose for geriatric patients. There is a marked increase in the systemic exposure to treprostinil in hepatically impaired patients. Please see full prescribing information and patient information at www.orenitram.com or call 1-877-UNITHER, 1-877-864-8437.